talking with Bryan and Betty today, who's actually working at Pharmac, and he has got some interesting data that has come through on a research that's been done. So thanks for coming along, Bryan.
No problem.
Yeah. So what's your research been about?
So we got a summer student in to look at data around salbutamol prescribing. The interesting thing about salbutamol, we've got 3 products in the market. One's Ventolin, which is a branded one. Then we've got 2 generics, Prescribing and Salbutamol. What we discovered was over 50% of dispensed scripts with Ventolin in the marketplace. And what's interesting about that is Ventolin's got a co-payment on it. So essentially patients in New Zealand are paying approximately $4 million a year on a co-payment for an equivalent medication. Ventolin as to the generic.
Wow, yeah. And I mean, do you think there's factors involved in that? Because I know my patients, probably there's a belief system around, Ventolin's Ventolin and I only have Ventolin. But do you think there's anything around why they would be doing that?
It's really hard to pinpoint why it's occurring. But we do know from research that there's 3 major influences on the way patients start to think about a medication. Number 1 is the prescriber. That's us as general practitioners. Number 2 is the pharmacists themselves and where the dispensing actually occurs and what they give to the patient. And number 3 is the media and how that drives perceptions. So somewhere in that mix, patients are getting the perception maybe that Ventolin is superior to Salbutamol and Prescribing. Very hard to pinpoint what's actually driving it though.
So are you going to do some more research into that sort of stuff?
I think we'd like to understand it a bit more. I think it would be a really interesting thing to understand, and it's that connection between patient belief and how that belief is often driven by the professionals patients come into contact with. Because the other thing that's really, really interesting about the figures is in the most highly deprived areas of New Zealand, about 40-45% of the spaces or of the devices dispensed are Ventolin. So in the highest deprivation areas, 40% of patients are paying extra for the medication.
So this is dispensing data, it's not actually what's prescribed on the prescription?
No, it's actually what's dispensed.
Wow.
It's what's dispensed.
Because I know that if I write a prescription for Ventolin that's got generic on it, a substitution, then often they will end up with a generic substitution.
Well, they do and they don't.
Yeah.
Because we did a breakdown, we managed to in the end look at about 400 scripts, 350 to 400 scripts, and look at what was actually going on. And a couple of really interesting things showed up. That if you did write Prescribing or Salbutamol per se, you were more likely to get that inhaler. If you wrote Salbutamol, that is a pure generic name, about a third of the dispensings were actually Ventolin.
Wow.
But if you wrote the actual name, you were more likely to get the actual branded, the brand name. So you were more likely to get a generic if you didn't write the generic term.
That's really interesting.
Does that make sense?
Yeah, because I mean, I assume that if I wrote Salbutamol, then they'll be getting the cheapest version.
Not necessarily. No. Now, these are very small figures, and there'd need to be more thing, but it's maybe indicative that it's slightly more complex than we assume. And I know we push a line that you should be writing generic rather than brand names because they do change under the system we've got. I found that really, really interesting that little fact came out.
And I think it's probably just Ventolin or Salbutamol is so widely prescribed. I mean, and there's a lot of other drugs that are so widely prescribed as well, and we just write our prescription at one end and assume things are going to happen at the other end.
Yeah, we do. We make a lot of assumptions.
We do,
but a lot of decisions made at the other end that may not be in line with what happens. Now, we don't know whether the patient themselves are driving that or it's being driven by the pharmacist. It's really hard to say. But we do sort of know from the research that's been done into this that the patient's perception is very much driven by the attitude of the prescriber and also the attitude of the dispensing pharmacist.
Very good. And I mean, I've had conversations with patients at times about, well, actually that new inhaler you gave me works. And I know that when the first probably generic came in for Salbutamol, that we did struggle a little bit with the actual device and mechanisms and things. And, I think once something's been tainted, it's hard to push people along and keep on encouraging in a direction that we want people to go.
Oh, look, I think that's right. Those initial impressions, or what actually happens up front, are very, very difficult to change down the track once that occurs. And I mean, look, you see it in some of the things we've seen in the past where branded medication had maybe gone to generic.
Yeah.
And there's always sort of a surge in complaints or issues around the medication. Often what you find is new patients put on the generic, there's no problem. It's really interesting.
It's the changes,
it's just what happens.
So you've been in your Pharmac role for how long now?
Oh, just over a year.
Yeah, and how's it been going?
Oh, look, it's great. I mean, it's I suppose it's getting used to working at a national level in terms of how the system works. It's getting used to that conflict that often arises between my role as a doctor and my individual patients and what I want to do for them versus what is actually a national equity issue and access issue that's based on a whole lot of bigger dynamics, but I find that intrinsically interesting. The other big plus to the role is I've really been able to put primary care and general practice back into the thinking of Pharmac itself, which I think is really, really important.
That's great. It's pretty good that you're in there and enjoying your role, and I hope it goes well for you. And it'll be interesting to see what comes out with the next lot of research if you look forward to it. That's great. Thanks very much.
Excellent.